bắt đầu đi. Chương trình đủ chưa? Đủ nhân sự chưa? Không.
Đây là thiếu chút trễ. Đây
Bây giờ rồi, bây giờ thấy ấm cúng rồi ha.
Team B là dán hai.
Bây giờ ok, bây giờ mấy em biết cái vụ mà cái format bữa nay chưa? Cái format bên này là tôi đưa cái ca, rồi tôi đưa cái history, đưa cái examination, rồi đưa mấy cái câu trả lời thẳng vô lời, khỏi phải tốn thời gian tìm hiểu ha. Thì bây giờ là mỗi team nó còn là 3 người, nếu mà vắng một người thì 2 người phải làm cái ca đó. Thì giờ các em cứ nghĩ là đây một cái ca này giống như đang trình ví dụ trong một cái buổi họp vậy đó. Cái này không phải, nó có 3 cái loại mà presentation. First of all là coi như là handover, hello round, giống như buổi sáng là Việt Nam họ nói giao ban gì something gì đó, thì cái đó nó short. Bây giờ là mình nói cái case thứ hai là trong mấy cái meeting là giống như mình có cái case này, nó gọi là education case hoặc là education meeting, hay là kêu làm bà chủ vô bà chủ thức dậy ơi. Ok, thì cái loại mà thứ hai nó gọi là presentation ở trong mấy cái meeting, nó gọi là longer presentation, tức là khi mình present một cái case này á, rồi mình làm history, rồi mình làm một cái some part of education, tức là mình explain cho người ta là biết lại case là sao để anh ta học. Cái đó thường mỗi tháng này giống như nó có cái ca gọi là mortality, morbidity, hay là gì đó, hay là gọi là education đó. Thì cái hôm nay là tôi mua rồi cái ca cái ba nữa là trong mấy cái conference, big conference, mình present mấy cái study này nọ. Rồi cái thứ tư là cái scientific presentation. Thì bữa nay á, là mình cái format của mình là gọi là loại format thứ nhì đi, nó gọi là presentation, education presentation. Thì mong muốn em chỉ là muốn em làm communication, làm sao để trình một cái ca ra, present the case, people understand what you're saying, and also they follow what you're talking about and what the consequence, what chronological, chứ cần event history, cái timeline, and also at the end you have to educate them about the case, what they going to learn from the case. Okay. Okay.
Bớt nội 200 lon bia có khác.
Nghe không?
Dạ nghe. Nghe thì ơi.
Ok, rồi cái case bây giờ nó có hai cái loại presentation, either you do oral presentation or visual presentation. You have two choices. You can do oral presentation. I preferable student would do the first part, the history part, and you have to be, you got plenty time to prepare. You should do it clearly and precisely. And second part, whoever next will do the examination and investigation. And lastly, a little bit difficult, I think the doctor will do the last part and the key point. So I like the team A. Team A have enough people?
Team A. No, Trúc is absent. She's having a shift.
You have two cases. In which can you do case number 1, number 2?
Okay. Now the first case I will choose number 1.
3 people in the case have to do proper presentation, a history, all the case I have written to you, and it's very clear. You should know how to present this case. Right, team A, can you do? They got 2 cases there: gynecology and obstetrics. So which one you like to do first?
Gynecology.
All right, okay, go on now. Go first one? Have to do you need to look into the camera and you look at like present, you know, like presume that you are talking to the audience. You have to use two parts, verbal and non-verbal, and clear, and make sure eye contact with the audience. So we understand you're not going to read it from your book or from your paper. Or you can read, but you have to look at audience, to have to observe the audience, you know, respond to you. Okay, let me do the first one.
Oh, okay. The first case we talk about a 26 years old female missed our hospital because of abdominal pain in her lower right quadrant area, but now it's generalized and going with abdominal pain. She feel nausea, she's vomiting and feel pain in her stomach. And these symptoms occurred just 2 hours ago. About his medical history, she noticed that he didn't have menstrual hemorrhage for 1 month, and she had an abortion 2 years ago because of chlamydia. He had a regular partner, but often forgot using condom. That is about his her present complaint and medical history.
Okay, next person. Yep.
Yeah, about the examinations of this case. Overall, the patient is pale, unwell, and drowsy, with the hands are clammy and cool. I checked the vital signs, and I know that she is hypothermia, tachycardia, and hypotension. About abdomen examination, abdomen is distended. About when patient is a tenderness and no obviously palpable masses, and vaginal examination is not being carried out. About the investigation, it showed that the patient is pregnant because urinary pregnancy test is positive. We can see that there is acute blood loss through the complete blood count, with the hemoglobin is 9.6 and MCV is 87 fetoliter. And with the kidney function is still normal. And about this, I can summarize. There is a volume loss, short size. There is pale, rosy, unwell, clammy hands, tachycardia, and hypotension. There is signs of peritonitis, distended abdomen, tenderness, and guarding, and the sign of ruptured mass because no obviously palpable masses. It shows that there is intra-abdominal bleeding and leading to peritonitis, and make the patient is so painful, so that vaginal examination has not been carried out. And then invite Dr. Fu.
Okay, so we have a woman admitted to the hospital because she had lower abdominal pains and she's feeling unwell. And after doing the examination and the investigation, we can conclude that she is having a ruptured ectopic pregnancy. So, and she is also having some signs of hypovolemic shock. So our management will be divided into two main points. The first is the management for giving blood loss in hypovolemic shock, and the management for the ruptured ectopic pregnancy. So about the first group, we should have the patient lying flat with her head down, provide her with the oxygen via the cannula, and we should try to expand her volume by using some crystal fluid about 2 liters, and we should have some blood transfusion about 3 to 4 units. And besides that, we should move her quickly to the theater or the operation room to do the CTUMP. Yes. That's all we should do to manage this case.
Okay. Now the question of the audience, do you have any comments about this presentation? Please, democracy, I want to hear from you. You got to help us to improve. So there are a few things you should pick along, either pronunciation, communication, differential diagnosis, and the management. I'd like to hear from the table. Come on, your chance to kill them. Silent. Okay. Do you pick out any mispronunciation along the line? Or some medical words aren't, appropriate? Come on, I need to hear. Anyone, please speak up from the big table. I presume you have listening. You have listened to the case. If you have listened to the case, you should pick out quite a few points there. Yes? Okay. No. All right. Okay. I hope next case I need to want you guys to pay more attention, and I need to get feedback from from audience. Okay. Anh Văn, can you pick? What do you think of presentation so far?
I think that they prepare somewhat, but not make the audience feel interesting. It's not interesting at all. You have to show how to make the attractive, some interesting from your presentation. Okay. And some pronunciation, I think that maybe you mispronunciation, like shoulder, because a little bit it's hard to pronounce it, so you have to pronounce it again. Some medical terms I didn't catch much because I was have attractive from something else, but in general you present in full detail, but how to make it more interesting to people. That's what I would like to hear from you. Thanks.
Okay. Chị Loan có ý kiến gì không?
Microphone, Dr. Loan.
I think I have no idea.
Okay. All right. So I think probably this case quite simple, and I need a bit more interesting when you're presenting case. I think the first person presenting okay in a way, but I need a bit more like the 26-year-old lady who presented with the 6-week or what amenorrhea. There's no such menstrual hemorrhage. We have to use amenorrhea, the term. I mean, she hasn't had a period for 6 weeks. something to use the term inappropriately, and you have to get a bit more history. You know, I gave the history. You have to make up history. Somehow I can follow the history and a bit more interesting. I think and when you become nervous, the pronunciation become, you know, a problem. And also we can pick out, you know, you get more Vietnamese accent when you're speaking. And the examination, investigation, it's fine, okay, but you need somehow why you put MCV in there. It's MCV probably okay. You can use a term, a medical term like, you know, when you say the patient got low hemoglobin at 9.6 and the blood picture show that hypochromic, macrocytic or microcytic. That makes sense when you're talking to medical audience. Sometimes you tell MCV 987, we don't know what 87 means. I know the 80 is normal, but some people don't know. You have to give us a picture like microcytic or macrocytic, hypochromic or hyperchromic. And those, and you can go on to a lot of things, teardrop cells, anesthesia, a lot of things. So that's the important thing. And secondly, and also with, you know, the other thing, just the diagnosis, you can't go straight into the diagnosis. You have to give us differential diagnosis. I know that it's the office case, it look like a rupture ectopic, but what happened to something else? You know, you can't just straight in. My differential diagnosis will be rupture of ovarian cyst or something else, and you know, and also, but my main concern is the rupture ectopic, and this is an emergency. I have to act on emergency because patient look like patient got interrupted peritoneal bleeding, and now move to full have to move this case into patient emergency. You give a picture of emergency. If the patient got positive pregnancy test, and she's about 6 weeks in amenorrhea, she had, you know, low hemoglobin, she got a sign of rupture ectopic. I need to act quickly. First of all, have the resuscitation of the patient. That have to use a term. When you say resuscitation, that means we try to, you know, to revitalize a woman. Like have to put a 2 large bore cannula, give them fluid. I'm not sure, I didn't catch you with the blood infusion. I'm not sure why blood infusion yet. 9.6, usually we don't do blood infusion, but you do group and hold to get the blood ready for if just in case need blood infusion. And we need to organize the emergency operating theater. We need to do, you know, laparoscopy, laparotomy, explore for the cause of bleeding. If the rupture ectopic, we have to do self-injectomy. You give the picture, you know, chronological picture, emergency thing, people understand what you're talking. So just somehow, you know, it's just not really into scenery yet. I know that's a difficult case presenting this way, but I want the next, you know, group have to be a bit more, you know, just slowly, take time. Don't speak too fast. You can look on your nose and you can look up to the audience, but don't just think, oh, I remember this thing. I say what I remember. You want. Even when I do presentation in the group, I'm still have to look at the notes. I have no way I can memorize everything I want to say. Always at the point, you're not sure, you write a point form, then you look at point form, and expand on your point form. Don't rely on your memory. In no way. You make it look very, you know, like you like little student talking. Again, but I could first started. Okay, we use that as a baseline, and we move on. Next one, I want the next group has to be more, you know, slower, and look at the notes and give me something more clearly, and that the case has been set for you. You have got 2 whole week to prepare, so I need a bit more to input into it. Okay. Now, okay, thank you. So we go to team B. I need to go to team B for the first case and go. And also the student, please listen and help us to either give positive feedback. You don't need to give a negative feedback. You can give a positive feedback to say, oh, they speak very well, speak clearly. I like to hear, but at some point I want to clearer. Some sort of contribution, not criticize them, but you can give them some feedback in positive way. Okay. Now it's third, the team B. Okay, now can you give me the history first? And I want the flowing. Okay, after to finish, the next person come in. Now I'll presenting this way and come on. There's no gap in between.
My case is a 29 years old woman. Can you hear me?
Can you get a bit volume up?
You may move the microphone close to you. It's okay. You don't need to change your position.
The microphone is multi-directional, so you can move. You can turn the camera. All right, ready? Fine. Clear. Don't. There's a. We help you. Okay. Okay. Just try calm, slow. If you speak too fast, you make mistake. I want you very slow and clear. We're not criticize you when you speak slow. Okay. Be clear, slowly and calm, relax. Okay.
No, we couldn't hear anything. Hey, check it.
Yeah, I can hear now.
Okay.
Yes.
Okay. Slow.
Yes. My case is a 29 years old woman. She go to the hospital because she has a fever. She had a cesarean section 3 weeks ago and was recovering. She is breastfeeding. Until 2 days ago, she became fever, cold, and shivery. Besides, she has appetite, nausea, vomiting, and lethargy. And she had very short nipples since the birth. And in the last 24 hours, her left breast has become short and red. But medical history and family history doesn't have problem. And about examination, the cesarean section wound and lochia are improving. She has 4 points of SIAS syndrome. The first, her temperature is 38.6 degrees Celsius and heart rate is 106 beats per minute. And the left breast is a well demarcated area of redness over the superior lateral aspect and tender and hard to touch. And other body of patient is normal. And Naman will explain results of investigations and we diagnose and different diagnose.
Yes, and hello. So my first diagnosis is she got a mastitis because the symptom is happen very sudden, and she's may get feel like she's having the flu, such as fatigue or shivering, and usually she may feel pain in one side of her breast, and besides that, she also have the tender on her breast, and it is warm to the touch, and also she got the fever of 38.6 degrees of Celsius, and I also, beside the mastitis, I also think of the breast abscess, which happens when the mastitis isn't treated quickly. and which can be with the breast abscess, we can palpate mass in the breast, and also the mastitis is usually the result of a blocked milk duct, and sometimes the milk is back up behind the blocked duct, and it can be forced into the nearby tissue of the breast, and that is cause the tissue to be inflamed. And turning to the investigation, we can see that the hemoglobin is slightly decreased to 10.1, and can be due to the contamination of the vaginal discharge. It can the hemoglobin is slightly low, which can occur with a symptom of sepsis, and also it is common after the delivery pregnant, and then in the ureterolysis there is blood and protein, which can due to the contamination in the vaginal discharge, but there is no proof that she's have the urinary tract inflammation, and also the CRP is rising, and it can suggest a significant bacterial septic process, and also the urea is raised, and sometimes she's having the dehydration to the sepsis, and also the postpartum paresthesia and vomiting. Okay.
And about the patient has infection, so she should be admitted for intravenous antibiotics. The commonest organism is Staphylococcus from the skin. So the first I would like to use fluvoxacillin for her, and if she doesn't improve within 24 hours, I will use antibiotic with consultation microbiologist, and if we think that the patient can be an abscess, we would need needle aspiration under local anesthetic, and besides she is foaming and dehydration, so she needs to use antiemetic, and she needs to complete fluids, and using the rod and analgesics are necessary to reduce breast pain, and besides to prevent unblock the duct, I will try to continue breastfeeding, or if this is too painful, she should extract milk.
And finally, we have some key points for you. And the first, mastitis is a common cause of puerperal paresthesia, and as well as antibiotic management include continued breastfeeding from both breasts or expressing milk to unblock the duct is also important. And that's it. That is all about our case. And thank you for your listening.
Okay, audience. I want your feedback, please.
Okay, so I have some.
Just 1 second, Hannah. 1 second. chờ xíu.
Em cái gì vậy? Em cái gì?
Cái hỏi gì vậy?
Nôn sữa đẻ gì?
Okay.
Yes, so I have some feedback for Team B. Actually, I think that they have improvement from my team presentation. Quite fluent and really clear content to follow. However, I still heard some mispronounced words. Like chivalry, appetite, nipples, or demarcated area. And I don't know what is delivery pregnant means. And I cannot hear the words postpartum, and there's something after, but I cannot hear it clearly. And I have some questions for Team B. Did your team read anything about expressing milk to unblock the duct? And the mastitis I have read in here is some kind of like infection, but is there any situation that it's just the inflammation of the milk duct without infection? Because in Vietnam, after a woman delivered the baby in the postpartum period, they have the 5th day fever. Sốt ngày thứ 5. Sốt lên sữa, but I don't know what we can pronounce it in English. Yeah, so that's all my questions and opinion about Team B.
Okay. Team B allowed to respond. Q, hi back.
Yes. First about postpartum paresthesia, and that's mean
I'm sorry, pyrexia.
Pyrexia.
Pyrexia. You know Rex? Pyrexia. Can you tell me, you know Rex Hotel in Saigon? Called Pyrexia.
Yes, pyrexia.
Okay.
And that means it is common condition sometimes happen when women give birth, and it can happen about few days after the delivery, and as you know, the most common cause of this is the mastitis. And about the next questions, the mastitis sometimes is the block of the milk duct, and it can happen with the non-inflammation, and also it can happen with the inflammation. And if we don't treat it well, it can lead to the breast abscess.
Okay, good. Okay, now the audience, the Team B had mentioned CRP. Is anyone can tell me what CRP is and why does he mentioned CRP?
Protein.
Okay. I think that Dr. Wang and Naman want to mention about C routine, C reaction, C reactive routine. Yes, but
Okay.
in we usually read a CRP. Yes.
Okay, good. Okay, now secondly, I've got a question for the Team B. How do you know the patient got a staphylococcus your aureus. What evidence to prove that before you give the patient antibiotics? I presume that you say that commonly the patient, but it's some test you have missed.
The patient, I use antibiotic for the patient because she has the fever and she has 2 per 4 points of SIAS syndrome, and she has the CAP and white blood count is high. So I think she needs to use the antibiotic treatment.
Okay, good. But I think one thing to add, you need to do blood cultures. You're looking for bacteria, which type bacteria, and you need to consider sensitivity of the bacteria to the antibiotics. Okay, with abscess, does the abscess that happen that quickly?
No.
Okay. All right. Okay. All right. Good. I'll leave it. They should know. They have to look about what is an abscess, and why abscess not happen like sudden, like it's only 2 days post delivery, which is unlikely abscess. So why I make that statement, that this is important for you not only in obstetric, but later we look at the patient post-op infection, or some instead the patient day 1 post-op got an abscess, which I say no. If my registrar might ask me, say the patient had abscess, I would say no. You have to convince to tell me why I say no that the patient didn't have abscess. Abscess is different, the whole process of things. So I need to think about it, and that's something they need to learn about things. So now that's good. Thank you. Much better, and you speak clear. But I think you need to look at me. Doctor, what's your name again? I forgot. I keep forgetting the name. You need to look at us. You keep, when you read the sentence, when you get that like full stop, just stop there and look at the audience, and look and read again. Just keep reading, and it's not like 26-year-old lady who presenting with pyrexia 2 day post C-section, full stop. That you write a sentence, that when that's full stop, you need to look up to the audience. You look at them, you give a 1 or 2 second pause. At the time you can look at people, and you go back to read the next sentence, look at the patient, look at the audience again. You learn that next one. All right, good, great. Thank you very much for audience had made feedback.
Wait. we have one question that Timmy not answer yet.
Oh, you want to kill him? What question was it? I forgot.
About the 5-day fever.
You asked about sốt lên sữa.
Yes.
I answer the question. If the patient has sốt lên sữa.
What's in Vietnamese? I can give you the medical term in English. What is it? Yeah, what question is it? What's it? Huh? What?
The patient has fever because he's producing the milk. So we don't have the time for that. Usually on the 5th day after giving birth.
Ngày thứ ba.
Third day.
No, colostrum, you mean? Okay. I skip. Let me think about it. I'll give you a medical term. Okay, good. Okay, give answer the question. Yeah. Sốt lên sữa. Sốt lên sữa. Okay. I don't know what the term. Okay.
I'm not sure 100% about it, medical term about that, but usually we call it postpartum fever, and Vietnamese nation, because
all right. Okay.
They say that when the mother begins to have the milk for breastfeeding, they have some kind of fever, but we're not clear yet why you have the fever, because you have the the milk production from the breast.
All right. Okay. Okay.
Too much noisy now.
I have some talk about with two teams. I listened to cases from your presentation, but I feel about you guys not report good about vital sign. The first class, I think about Dr. Dane talk so much about how you report vital sign, but you still keep look like you translate directly from Vietnamese. I hope the next case you can use completely like American way or English or something. You don't need to talk like 100 speak 4 minutes. We don't need it. Look like you say heart rate 100. That's it. We don't need do so detail. And other one, blood pressure, you just say about 100 per 60. I think every people understand about this. Okay, thank you. And other one, I need to tell you about look, you diagnose the patient infection. We need the blood count. Look like I heard Dr. Vân say high white blood pressure final, but when you report, I don't heard it. Maybe I mistake or you missing. Another one I agree with Dr. Fu. When you give antibiotics, you need for clear the patient infection, what kind bacteria. We need to do culture. We don't use the same way in Vietnam before. I worked in Vietnam before. Every patient come in with antibiotics. We just do it. That means we get a lot for the problem and when we use antibiotics right now. Okay, thank you.
All right, good, Tim B. I think I probably can give you a whole lecture about your mastitis or breast abscess and how to treat, but I think our main goal is communication. So I'll leave the part of technical thing or medical thing, leave it, but I'll call Team C. Thank you, Team B. Prepare for the next one. And now Team C. Thank you.
I know.
And Team A, get ready for the next one.
Dr. Fu, can you shut down the microphone from ObGyn? I noticed that someone turned on that.
You want to turn on or off? I can't.
I want to turn off that ObGyn.
No, we can't because it's on the Zoom meeting. You have to turn it off because we don't have a control of that. If it's a Zoom webinar, we can control that. On the Zoom meeting, everybody have to control their sounds and their video.
Okay, get ready. We run out of time.
Okay.
You know, when you go to a real meeting, in a meeting they give you 5 minutes. 5 minutes after you run over, they will shut your presentation. Okay.
Hello, teacher. About my case is gynecology.
Right.
Yeah. About the history, the patient is a woman and she's 39 years old, and she referred from the hematologist with anemia, and she had complained with me. She had a tightness, short of breath, for 3 months ago, and she has already had it. About her menstrual cycle, it occurs every 24 days, and the first day she had this is a general moderate, and the second through the fourth day is very heavy. And she told me that she also use tampon and sanitary towel together, and she had no band. And the last meal test were normal 2 years ago. And about the past medical history, he has no period, gynecological problem, and take no medication. So I take examination with her, and I look her. She so very slim and with bone consistency, and I check abdominal, perineal, and speculum examination are unremarkable. And after I test it, and I give her to do some tests to want to know exactly that she has anemia. So the first test is blood test, and as you can see the result I give you, and the blood test show anemia with reduced main cell volume and low main cell hemoglobin. This gets rid of myrocytic anemia. Besides that, she has iron deficiency is the most commonest cause for this picture, and it is confirmed by the lower ferritin and iron, with raised iron binding capacity. And so I think it's bloodstream is hypoconic microcytic red cells, and some symptoms he has that in common with that the anemia account for the restlessness and tiredness and headache. And another test I will give her is transvaginal ultrasound scan report, and the result is the uterus is normal size and retroverted, and the endometrium is smooth and thin. It's measuring 3 to 1 millimeter, and both ovaries are normal. That's all. And
So about my diagnosis, I think menorrhagia is the commonest cause of anemia in women, and in this case, the patient has the history of excessive bleeding. The woman herself may not recognize that her periods are particularly heavy if she has always experienced heavy periods, or if she thinks it is normal for periods to become heavier as she gets older. And no other cause of heavy bleeding is apparent from the history, and the ultrasound is normal. Then the underlying mastitis is one of exclusion referred to as dysfunctional uterine bleeding. For the management of the patient, I will give the patient the iron supplement with ferrous sulfate, 200 milligrams twice a day, and until her hemoglobin
and ferritin becomes normal. Maybe it may take about 3 to 6 months to restore fully. Another medication I can give the tranexamic acid during the menstruation to reduce the amount of bleeding. But I need to find if the woman have a history of thromboembolic disease. So I think we I think the level node adjusted releasing intrauterine device is used for its action on the endometrium to reduce the menorrhagia, often causing amenorrhea. So it is commonly associated with irregular bleeding for the first 3 months. The commonest combined oral contraceptive pill is effective for menorrhagia in young women. So, if these first line management are not work, then the endometrial ablation should be considered. Also, the hysterectomy is considered as a last choice for DUB due to the associated morbidity. So that's on our about our.
Okay. First, I want to ask Team C. You give your own feedback. How did you fare? How did you go with your presentation? Good, bad, or something you need to to improve?
Yeah, written is a little good.
Little good, and what's little good? What English? What can you translate?
No, I think it's fair.
Okay, fair. Okay, right. Okay. Now, class, please give them a feedback. Quickly, we need to be quick, please. Feedback. One. What Team C? Team A, give them feedback quickly.
I think that Tuấn and Tuyền, Tuấn and Thảo, they are like getting better through each session, and I think they are more confident to present the case. It's quite clear and follow the structure that Chuku have already given us. So therefore, easily to follow.
But besides that, I can recognize some text that Thảo done that. She has some mispronunciation, just like the term conjunctive, and the mean cell volume, And with investigation, I'll just say the blood test. I think the full blood count is more appropriate. Yeah. It's our feedback from teammate.
Okay. Can you hear me now? Okay. So I think the last part, like Tuấn, I assume he's reading directly from my text. I can see, I can hear that. He much more confident when he speak. He look at audience. Thảo seem quite clear, can pronounce okay. So we need to, and also I have posted few questions on the chat. Have anyone can read it? Anyone can read on the chat? Can you read on the chat?
How to read? Yeah.
Okay.
So you want me to read out?
No. I think we don't have time, but I'll give it interesting, the question. You need to look at the chat. The question I'm asking the class, they're quite good for you to do learning, like iron study. I need to know how to interpreting, the result, the iron study, and few other thing. I'm gonna typing along, so you just take it home and just read it, and for your own benefit, and see what you learn from it. We don't have time to go into technical each one. And if I got time in the end, you want to ask me, I can go through with you very quickly. Okay, so I think it's good presentation, but when you do, when you present examination, I probably prefer you not using I. Just say on examination, there are this and that, speculum examination, show. Don't say I do it. Just say, when you present the case, I will not use I. Okay? So use on examination, the patient is stable, she had the blood loss, and speculum examination show, no vagina bleeding, blah, blah, blah. That's all the thing, rather than I. Okay, good thing. But probably they well prepared, but somehow, Tuấn still reading from my text, so I'll be, try to make your own, so you can learn from it. So now, what next one? I want to call in reverse order. I want to call Team B for the next one. Team A. You want to do Team A? Just you're sitting there, fool. Just do Team A then. Okay. All right. Team A. Okay. Well, you have to swap around.
Yeah.
Trúc not here, yeah? Okay, so we do Team B. Which one? Which team?
No. Sorry, but Trúc cannot attend.
Okay, all right. Okay, all right. So you go to Team A then.
So we can cover her part.
Okay, all right, good. Okay. Do better.
Okay. Our case this time is about a 39-year-old mystic hospital because her first time of pregnant twin baby and twins baby. Her delivery finished 2 years ago. 2 hours ago. At 38 and 4th day, 38 week 4th day. Via investigation, I can detect that the growth and liquor volume of the baby is in normal range, and due to 30 minutes of instant passing in second phase of delivery and the deceleration of cardio tachograph. She has helped to in delivery by ventals, and when I came delivery room, I can figure out three things. That the first thing is the placenta appear completely. The second thing that intravenous cannula and epidural cannula are static. The first thing is that she is bleeding severely because I can see that the cyst is choked by blood, and in the kidney disc I can see we have more than 500 millimeter of blood clot. So I can evaluate this case. It's just a complicated condition. So I will ask my seniors for more management and examination in this case.
Okay, so after we have the history of the woman, we come to the examination. Actually, she conscious, but she's conscious, but she's drowsy and pale. And pale is because of her blood loss, and the temperature is 35.9 degrees Celsius. It means it's a little bit low. The blood pressure is normal, 120 per 70, and the heart rate is a little bit fast, 112. The periphery feel cold, and all the things happen because her body try to compensate for the hypothermia, and we have the explanation for the uterus contraction. The uterus is palpable and up to the umbilicus. It means it's and it feels soft. Therefore, the construction is not really good. And about the abdomen, it's soft and non-tender. On the vaginal inspection, we check for a second degree tear, which has been surgery, but it's okay. And we cannot looking for more things than because of the blood come out from come out. Yeah, so we try to we do some paraclinical examination. We do the complete blood count, and the hemoglobin is 7.2. In the it's in the medium level of blood loss, and the mean cell volume is normal. White cell count quite low, 3.2, and the platelet also quite low, about 131. The INR is a little bit high, 1.3, and other thing is all the other thing is the urea is quite increased, 5.2, and yeah, and the left is normal rate. So we think that she has the primary postpartum hemorrhage, PPH, because she has some risk factor, like she has a uterine anatomy. We can check it by examination. The uterus is soft and it's high, it's up to the umbilicus. And then we have she delivered she sorry. She delivered twins. We can call it multi-part parity, and she has 2 risk factors for having the primary postpartum hemorrhage. So this is the emergency situation in obstetrics. Therefore, we have to manage. We have to have the management strategy immediately. We have to wrap up the contraction by placing the hand on the over the uterus and rubbing it and squeeze it until it's become firm. And we have to ensure that we insert 2 large bore cannules for intravenous fluid, and her hemoglobin is 7.2. It's not indicate a blood transfusion. However, we have to prepare it because we don't know what will happen next. Maybe maybe all the treatment doesn't work and she can bleed more, and she will require blood transfusion. And we have to do cross-match at the same time. We have to check for the full blood count and the coagulation again. We have to come. Although she hears that her blood pressure is normal, the flow rate is just a little bit high. Everything seems like normal. However, it's just the compensation of her body with the blood loss. So actually, she actually had the blood, the hypovolemia. So we have to commit the intravenous fluid for the volume expansion, and we have to indicate her some uteral tonus, like ergometrin, intramuscularly. I don't. In Vietnam, we actually do the intramuscularly 500 microgram to enhance the uterine contraction. And if it doesn't work, we will have to use other uteral tonics like misoprostol or sapropros. And if it doesn't work, we have to get her to access to the anesthetic theater for the procedure like the uterine artery embolization or laparotomy with a B-link hemostasis structure, or the uterine artery ligation, or even the worst vision is to have to do the hysterectomy. Yes.
Okay, can you make a conclusion now?
Yeah, okay, so this case is about a 39-year-old woman with her first pregnancy, delivered twin son 2 hours ago, and after deliver the baby, she appeared with heavily passing last clot of blood, and it's we can, and the measurement we can see like approximately 500 millimeter of blood clot in a kidney dish on the bed.
Can you just make me just one sentence of the summary of your case?
Okay, so the
just
diagnosis,
one sentence.
The diagnosis here is the primary postpartum hemorrhage because of uterine atomy.
Okay. Okay, good. Okay, all right, we stop here. I think first of all, I don't like the idea you're reading from your phone, you know, when you do a presentation. Okay. You seem like you're playing with, you're texting someone there. It sounds not very professional. Now, it's a very emergency case. I think the presentation, I think you lack of the awareness of the emergency. I tap time on the chat there. You act now, act now, act now. Patient is dying. You know, you're going to shock soon. So I think I need a feedback from Phú. You work in ICU, right, Phú?
Yes.
Okay, can you give me feedback to say how you act in this situation, emergency? I want any jargon. I want something to save the woman's life now.
Okay, so this is a emergency case, and we have two things to do spontaneously. The first thing is try to reverse the hypovolemic shock by using the volume expansion using crystal fluid, and especially the blood transfusion is needed because she lost a lot of blood. And so the first method is trying to control the shock by some methods that you are already familiar with, like oxygen, the patient position, and the volume expansion. And the second management is try to control the source of blood loss. And in that situation is due to uterine atomy. So we have some methods to control that, like try to rub up the uterine to make it contract more effectively. And we can use some drugs to make the uterine contract, like oxytocin or egometrin or other kind of uterine, I don't know the word, you know, that the drugs to help the uterine to contract. And the last method is to check for any trauma, any left or any retained placental tissue. And if we cannot control the blood bleeding, we have to stop it by using the artery embolization or try to direct.
Okay. All right. Okay. Thank you, Phú. It's great. In terms of, you know, you work in ICU, you can see all, you know, emergency thing. I have to say, a student in here 6-year course medicine, on the students should be familiar with your postpartum hemorrhage. I think you're using too many things to describe. The way presentation still quite, you know, I'm not sure, not the medical level yet. You're still using too many little things. You explain too many things. We don't want to know why the patient failed. You know the patient failed. The patient lost blood. Patient going to hypovolemic shock. So no, you don't need to know. You know, if you present the audience like, you know, like the doctors or students, we know that what caused the fail. So you don't need to go too much into it. Just really tell us, you know, this patient, you know, vital side, her blood pressure, what the blood pressure is, what, you know, pulse, what, you know, and in case this one, you got evidence of hemoglobin 7.2 and continuous bleeding, that she got to, you know, get the hypovolemic. But first of all, in all situations, I need to know, first of all, you're not the only person to care for the patient. You need to call for help. You're not only one, you're not a hero. You have to call for help. call for senior one to help you, because only you will not be able to manage a case. Regardless, I'm the consultant. I have to call someone else to your surrounding. So first of all, you have to ensure that the patient have some venous access. That you have to get a 2 large bore cannula, like full set. You need to get the fluid replacement. How you can do it? You have to get a very big cannula in case you get pump a lot of fluid, a lot of blood in. You need to check your blood count, and you need to do all other things. So I think I just got to be a little disappointing that you reading from the phone. I don't like idea. It's not the way how you're presenting, and it seems like you have not prepared the case well. If the case you can't read you need to put a point form and your expansion the point form within your head, not just your reading from from the little device. And you lack of awareness of the situation of emergency. Okay, that's now I'm not going too much in detail. And Văn.
Excuse me, I would like to ask Phương Thảo, just repeat 2 points, Dr. Phú Trọng. Just tell Dr. Phú. Because I just look at you and you just talk everything. You don't concentrate on what we are doing now.
Yeah. He said that we should read in us. He's not read the technology and
No. I just asked you. You just tell me 2 points, Dr. Phú Trọng. Just answer Dr. Phú. Did you hear anything? Did you listen anything? Just 2 points, very quick one. 2 points.
Yeah.
Yes.
The first, he said that we must come for help, and we.
No, that's from Dr. Phú. It's not from Dr. Phú Trọng.
Yeah. About Dr. Phú Trọng, he said that
Okay, next time, please, class, next time when your colleague, when your classmate talk to something, you have to pay attention to that, okay? You don't pay attention anytime. Now,
all right, okay.
Back to Ngọc Anh. Yes. I just want to...
Yeah.
About Ngọc Anh, I have a perception, something about Ngọc Anh. Because in this case, I have a feeling that you just base on your blood pressure too much. That's correct? Because you say that, you repair the blood transfusion, but they say there's not emergency yet, and blah, blah, blah. Basically, you don't feel it's an emergency, because I have the feeling that you just based on blood pressure. But you see that beside the blood pressure, you see the hemoglobin levels so low, and the heart rate is so fast. Yes, okay, please.
Yes, actually, I said that it is the emergency situation in the obstetrics. However, in this situation, her body is compensated for the hypovolemia. Therefore, her blood pressure is normal. However, we have the other thing like the heart rate is a little bit fast, and she pales. Therefore, we have to we have some some treatment for the emergency situation, like we have to transfusion the fluids to treat for her hypovolemia. However, her hemoglobin is 7.2. It's like in the mediate medium level of blood loss. Therefore, we don't have the at this time we don't have the indication for blood transfusion. However, we have to prepare for that. We have to do the cross match. We have to have the blood unit to prepare for the situation if she hemorrhage more in the future. Like, yeah.
Yeah, I understand what you are trying to. I understand what you are trying to remind, because when you are relying too much on blood pressure, and you may miss some important thinking about the situation. Like in this one, although the blood pressure is in normal range, but the patient may have shock already because you can see that she is very unwell and she has tachycardia, and it's more sensitive than blood pressure to let you know that the patient is having shock. So we have to be very careful in this situation.
Okay, that's good. I would like to tell you a little bit. You have to use your clinical judgment in the whole picture. Never rely only one side or symptom. You have to provide the whole picture. Okay, that's the main point I would like to tell you. Okay, so you don't feel the feeling of emergency here, because you say, oh, still good, huh? Or still stable, something. Okay, that's the main point I would like to tell. So Dr. Phú Trần, very good.
Okay, I'd like to add on for furthermore about blood loss. If you go back to physiology lecture in your first, second year, first, if the woman, your most obstetric patients are quite young, healthy. But if the first thing when you lost blood loss is the heart rate, gone up to try to compensate to pump out more blood out. When you lost about 1/3 of your blood volume, the blood pressure start dropping. So they might be, reliable on blood pressure. Might be you wait until when you lost, until the body cannot compensate anymore, and the blood pressure will drop. That she will go into hypovolemic shock. So 1/3 tachycardia, after 1/3 volume, your blood pressure will drop. That means that she can't compensate anymore. You don't want to wait until then. Okay, good. But we have to push on, and we don't want to go too much technical. So can I go back to what next team? Team B, is it? Team B, or who's the next one? I forgot. Lost in order. Which team you were before? Which team? Ngọc Anh, what team are you?
Yes.
What team are you? Team A or Team B?
Team A.
Now we go to Team B now. Team B. Oh, hello, Minh. Sleep well. I only have been slept for 2 hours. Okay. All right. Okay. So, 2 person. Okay. Can you show your best? Okay. Slow, clear, no stress. Okay. Do your best. Okay. We worry, don't worry about us. Just do whatever you can do.
So my case with G is 14-year-old girl has a lower abdominal pain. It is suddenly 1 day ago, and it occurred over the whole of her lower abdomen, but worse on the right side. It is intermittent at the first, but now it is constant and very severe. She feels unwell, no vomiting, and no appetite. Her bowels open normally and regular.
She pretty as well. The past medical history, she has the last menstrual cycle 2 days ago, 2 weeks ago, and she has slightly irregular cycle, and she has never medical problem in the past, and examination, she is in pain, and the temperature is 37.9 degrees Celsius. Blood, blood pressure is 150 over 74, being normal, and the pulse is 112 elevated. She feels warm, well perfused. Her abdomen is distended symmetrically with generalized tenderness. There is a mass in the right fossa, right iliac fossa region, and warning rebound in the right fossa region. The blood test show that she has an infection. That is why blood count is 14.2, and the CRP is 55 milligram per liter. Anything else in normal range, and then Jim will present the differential diagnosis and the investigation.
I will turn to the differential diagnosis. With a patient have an abdominal pain in the right iliac, I will divide into 3 groups of counts. The first related to gynecology, the second related to surgery, and the last related to urinary. The first count related to gynecological counts. There are 3 diagnostics we should mention. The first is ovarian. Sorry, there are 4. And the first one is ovarian cyst torsion. The second is ovarian cyst rupture. And the third is ovarian cyst hemorrhage. And the last is ectopic pregnancy. About how related to surgery, we just mentioned about appendicitis with rupture. And the last count related to urinary tract, we should mention about urinary tract infection or renal colic. With this girl is a 14-year-old girl. The first possible cause, I think that it is ovarian cyst torsion or inflammation of appendix, and this appendicitis can fracture. Yes. The related to ovarian cyst ruptures or hemorrhage is not popular in this patient because her blood pressure, heartbeat, and other vital signs is not suitable for the cause. I want to suggest more further investigation. This case include the first is pregnancy stage to include some how related to pregnancy. The second step we should mention about urinolysis to include the inflammation of urinary tract. The next investigation we should investigate abdominal ultrasound. With abdominal ultrasound, we can include the stone in the urinary tract. Yeah, and we can detect the appendicitis, or we can detect the ovarian sick person. Yeah, and if with the trans-abdominal ultrasound, we can detect the aneuploidy. We need to take a laparoscopy or laparoscopy or laparoscopy to on the count of ovarian situation. Yeah. And if the diagnosis is not clear between the ovarian situation or mastitis, we need to turn on between a gynecologist and a surgeon to take more investigation about this case. And Kim Young will return to the management of the treatment of this patient.
As she mentioned about, we think in this case a teenager with this symptom, and we think she has cyst ovary cyst torsion. So we have to do laparoscopy and laparotomy as soon as possible to rescue the ovary function. The prolonged ischemic, it will occur through a necrosis. About laparoscopy, we will detorsion. I do the laparoscopy and in the presence of necrosis, we will cystectomy to about prevention to the recurrence. There is no the risk factor of recurrence after the torsion is unknown, but recent research that is we suppressing the ovary by oral contraceptive or operating. That is, we are fixing the ovary cyst to the uterus and the abdomen want to avoid the chance to recover.
Good. Okay, G.
Yes.
Say gynecologist. Say gynecologist.
Gynecology.
Gynecologist. Not gynecology. Not gy. Okay. Guy.
Yes.
Go. No G. You're having so much trouble with G. Okay. Say girl. Okay, good. Not Joe. Okay. Girl. Guy. Gynecology. G, you're having trouble with the G. Okay, that's all. All right, class. Feedback, please.
Feedback.
Come on. Either positive or negative, doesn't matter.
No.
In my opinion, in this case, we are not a teacher and a student. We are not a doctor or a patient. So we don't need to be so much differential diagnosis and explain too much. For example, like we offer complete blood count or ultrasound, but in the case we do have this information, we just need to present it and give his conclusion as well. I think we don't need to say too much because this is an emergency case. Present to what we have.
Sorry for going, but I think in a medicine case, we should think more differential diagnosis to investigate more.
No, I mean, we don't think that's good to give many different diagnoses, but I mean that we do have the investigation. Yes, we have the figure, we have the value, so we can rule out this already, right?
Right. No, guys. We just have the blood test, and the vital signs. We don't have the ultrasound. We don't have the pregnancy test, and we don't have the urinalysis. Yes. Okay. So we have to do that to rule out.
Anyone? I love it. I need more. Come on, feedback. Yes. You don't need to fix it. You don't need to change the camera. We can see you. Just keep talking. Where exactly? Don't turn the camera. Yeah.
Yes. I think Ngân and Trí have a very good presentation about the case and show us very detailed information. But I think in the first part, Kim Ngân just reread on the information that that you give them. So I think maybe she can talk in her own language and talk in a short way for us to keep to get the information easier, not to reread on it.
Okay. Next team, who never come on.
Gypsy. Any comment?
You don't have to turn camera. We can see you all. Okay, just leave the talk.
My case is about obstetrics.
No. I want feedback. Not your. You're not. I want feedback.
Yeah, like
Kill them.
Understand. They have some good presentation. They have good organized, easy to understand and follow, and good pronunciation. Except one medical term that I have heard is oral contraceptive pill, right?
Yes.
Yeah, I think she is mispronounced this word. And she Kim Ngân has a lot of eye contact with the audience, so it's excellent.
Okay. Now, before you go to the next team, I'd like to remind you, when in real life, in practice, is there anyone in female who presenting with pelvic pain or vagina bleeding? You have to exclude the ectopic pregnancy. Ectopic pregnancy has to be proven otherwise. Simple pregnancy test. Pregnancy test negative, you can do everything else. But pregnancy positive, you have to think about ectopic. Always keep that in mind. Any woman in reproductive years coming with vagina bleeding or lower abdominal or lower pelvic pain, ectopic pregnancy has to be proven. Okay. Now you all other team before, you all have trouble with just simple thing. If they don't make a medical surgical history, you just say she had no significant medical surgical history. Just one line, one sentence. You don't need to elaborate it. She this and that. No, just very professional way. She had no medical or surgical history. She had no family history of any other illness. She doesn't take any medication. That's all. She doesn't take. You don't say, she don't take this and that. It doesn't take. That's all symptom. We don't want all the negative information. Something just have to be precise and short. And then lastly, I'd like to ask the class, what is the function of appendix?
What is the
you have to go to look in your it has a function.
Anyone want to answer this question?
Yes. Yes. I have read some documents related to the function of appendix, and I found that some documents say that appendix have a function of immunology. Appendix reveal some cell lympho B or lympho T, and in some case, if the patient have appendicitis and must cut the appendix, sometimes they will decrease their immunology function.
Okay, I think it's true, but one thing is one simple one. Well, you know what the function appendix? If you are the surgeon, we will have to make a joke. What the function appendix? Appendix is what the function appendix?
It's like to help the
surgeon taking appendix out. How many times you got appendicitis? The simple way, just a surgeon. The appendix function is to pay for the surgeon school, private school fee for their children. So they take it out, just they know function, but actually it had the function in early in neonatal and also in early phase with some immunity, producing immunity with especially lymphocyte. But anyway, just a joke. So most of the time, you think the surgeon take appendix out because they want to get the patient to pay for their their son's school fee. Anyway, next team, get off. I do who team C, isn't it? Right, team C, go on again. Okay. Right, I know that you're very eager. Ngân, isn't it? Okay. Tuyền, okay, now give me a bit better than the last one. Quite good. I like it, but I want you to do better. But important thing, relax, do your best, slow, no mumbling, and use some really professional way. And don't. I'm a doctor. I'm not a patient. I'm not a little one. So don't explain to me too much. Okay? Good.
So I will present to you an obstetrics case on 17 pregnant girl come to us with severe headache and reduced fetal movements. About her severe headache, it is located on her forehead and persisted despite of paracetamol. She also has blurred vision, nausea, epigastric discomfort, but no vomiting. She denies of leg or finger swelling. And her past medical history is her first pregnancy, but she didn't discover until 23 weeks. According to the reverse ultrasound scan, she now in her 37 weeks pregnancy, and her prenatal checkup, her blood pressure is about 120 over 68, and her urinalysis in negative is normal. So in the definition, her vital sign resent of the high blood pressure after repeated try. So we confirm that she has hypertension. She also has her face, her legs, and her finger is mild swollen. Her fundoscopy and her cardiovascular and her respiratory is normal. In the abdominal examination, we find that she has tender in the epigastrium and in the right costal margin. Her uterus is soft and no tender. About her fetus, it's in a cephalid position and 3 over 5 palpable. and the result of the investigation, her complete blood count is normal except the playlist is less than normal. It's about 126. Her renal function and her liver function is increased. Her urate and is also increased, and her urinalysis. So the proteinuria and her CTG is so a variable deceleration is our concern issue.
Based on the patient history and investigation, my diagnosis is severe eclampsia because the patient has a new onset of hypertension. Her blood pressure is greater than 160 millimeters of mercury. She also has proteinuria, and in addition, her blood tests show that she has liver dysfunctional. Her liver dysfunction. Her liver enzyme is greater than 2 times than normal value. Furthermore, the patient also has visual disturbance and severe headache. It's a feature of cerebral edema. And in addition, the patient is at high risk of preeclampsia because this is the first time she has pregnant, and she also a teenager. She is also 17 years old. About management, it's important to keep the patient status be stable. So at first, the patient should be admitted, insert intravenous cannula and blood coagulation check. I will also insert urinary catheter and monitor carefully the blood input and output to find signs of renal failure. About medication, consider to give her anti-hypertensive medication to keep the blood pressure is under control. In addition, I also give her magnesium sulfate infusion to reduce risk of seizure and eclampsia. When maternal status is stable, the blood test result is available, I will perform C-section to help the baby delivery. And about postnatal care, I will refer the patient to high deficiency room to have a good nurse until her blood pressure is normal, her renal output on blood tests are normal, and on the symptom are results. That's all about my case. Hello.
Doctor. Okay. Dr. Min, like he's. I'm not sure where are you sitting. I mean, look like in a hot air balloon or something. Or in something in jail somewhere, or Eiffel Tower. You like to add anything, Min?
Yes, it's been a while since med school, so I'm not sure the management of preeclampsia here. I just think that definitely need to stabilize the patients, pay attention to the mother and the fetus inside. But C-section for the patients, I don't know, unless there are other indication for that, or unless the fetus have distress inside it to take it out emergently. Otherwise, if you already stable the patient, I guess I'm not sure about that either.
Okay. All right, Thanh Minh. Class. I think C-section on delivery are probably that complicated. I don't want to go into detail. Probably I wouldn't do C-section first. I have access. Always try to get the patient at normal delivery. If the baby, the fetus indicate fetal distress, then I'll have to go to C-section. But I think at your level, I don't want to go deep into that level. So I'd say I want the class give me feedback. Come on, she tried to criticize you. Now your turn.
I have some feedback. I noticed that she has some menstrual like cerebral, something like that. And there's just one thing I remember that she said that her liver function increased. Is wrong. Test result increased, but the function is. So we have to make clear of that. Just one little point. And off you go.
Okay. Come on, other people, please. You can do so. Say something. Someone hasn't said anything. Please say something. Don't.
Okay.
You haven't said anything. Come on, say something. What do you think? How you say if they're good? Just tell them they're good presentation. Why they are good?
I think Jane has a good presentation. She follow all the instruction you give us, and I wonder if I have a question that what medication we use to decrease the blood pressure in preeclampsia women?
It's a very technical. I think probably we don't have time to go through. But again, as you mentioned some medication there. Okay, you didn't listen to it. I'm sure you did. She mentioned all medication, like magnesium sulfate, a lot of things. All right, we don't go into detail. Anything else? Anyone want to add on? Misspelling? I think one of misspelling, a terrible misspelling. Okay, might upset a lot of people. What's her mispronunciation?
Syphilis.
Yes, that's right. She said syphilis. You have to be careful. Yeah, cephalic, not syphilis. You say that to the husband, she has syphilis. That's it. You're gone. Cephalic, okay. And then lastly, I remind you, in whatever you do, obstetric is always involving two patients, mother and baby. Don't forget about baby. So the issue when you stabilize the mother, you have to monitor the fetus. Okay, always care about two patients at the same time. But then well done, good. Speak clearly, loud, clearly. And some less, explain in normal way. It's a good way. Okay. What team we up to now? Who next one? What team? What team were you?
I'm from Team C.
B. Oh, now can I have team C, please? Next one.
Then
I think Oda.
we have.
They're all done,
We
is
just
it?
had this game.
We finish all. How come it's so quick? How it's so quick?
Yeah, because we have the new facilities. Yeah, we don't have to move and we save a lot of time and we make it quick.
Yeah.
That's very good. Okay. I just probably might leave and bác sĩ Anh to give you a bit more feedback. But I like, something again, just a little bit polishing, a bit more in the way how you present the case and which audience you're presenting to, and use something that less, something when you present a fact, whether that fact affecting your, management or not. If not, then probably you skip it very quickly. If you think the fact like this patient had, like headache or visual disturbance, yes, it's true, then you have to, go deep in that. But something like, she doesn't have past medical surgical history, that's it, all done. And also the young said her past history, she pregnant something. It's not past history, she is at the moment, okay? So I think that's a good way how we interact this way, and we learn from other people's mistakes. We more concentrate on the way how we speak. It's still under pressure, we can see people making mistakes. That's normal. There's nothing wrong with it. But she Vân still had a little bit, when she nervous, she very into Vietnamese accent. So try to be confident. Try to get over that Vietnamese accent too much. And Thi has the same little problem too. Still got very strong Vietnamese accent. Try to improve it in your accent. But other people speak quite clear and well. And it's just, the matter, you speak more, you listen more, you're getting better. And be confident. Don't try to so fast. Just speak slowly and clearly, and never, learn from that. Okay, and Vân.
Hi, class. I'm very happy that today you have a lot of improvement to have your performance in medical English. Just one thing I would like to tell you again, just about the difference between your medical interview and your presentation. In your medical interview, you have to ask everything in detail. Meanwhile, in presentation, you just tell the main points only, the key points, and you don't tell everything, because otherwise people will forget. So today, you did a good job, but I like you to make shorter, precise, and just give the main point rather than go around and repeat what the medical history tell you. Something about pronunciation, you still have some problem with that. I would like to tell you, I make a list here. So beside the gynecology that Dr. Phu already tell you, never guy is a the most important that you usually mispronounce is antibiotics. Okay, because we in Vietnam, we follow the French one. Usually we say that antibiotic, antibiotic. No, you have to slow down about the old sound. Antibiotics. Okay, so R is higher, and you make a break there. Antibiotic, not antibiotic. It's not good. About Dr. Vân, try to practice more about the last syllable and the last sound of the words, like manage, not manage. It's not good at all. You should have to pay attention to the final consonant. Manage, something like that. And the most important that Dr. Phu always talk about you about the mature. Okay. mispronounce incorrectly almost everybody. Okay, so if you remember that the last sound, yeah, the last sound like poor, you know, nghèo, huh? Poor, sure, premature. Huh? So this is the most important mispronounce for everybody. And something about the word using. If you say that something is a noun, you say that swelling. But if it's an adjective, you say swollen. Okay? You just mix up with swelling and swollen. One is a noun and one is an adjective. And the other one, tenderness is a noun and tender adjective. Okay, so don't pay attention more about that. Yeah, so use correct words. Okay, so those are all. I just tell you something that I try to do because when you don't need to pronounce like the native speaker, but you have to pronounce it clearly so people can understand you. That's the most important. Okay, you don't need to speak like Mỹ hay nói gì gió. No, no, no.
G say my girlfriend.
My girlfriend.
No, my girlfriends.
Okay. Girlfriend.
No. Girl. Friends. Plural. Many girlfriends. Okay, just remember G. You're having a lot of trouble with G. Just go, right? Just go. Just say all the time, go, guy. Let's say. And Vâng, I think I agree with anh Vâng. You have to be careful with Vietnamese, monosyllables. You know, when they say I, tôi, anh, in English are multi-syllables. So a lot of time you're missing the last bit of it. And sound like, that's why your accent becomes very Vietnamese, because you try somehow, you're missing the last bit. So like antibiotics, something you antibiotic, something you're missing the last one, that's fun. Try to be careful, break it into little, one section and say again, and that you will get away from, the Vietnamese accent in that way. And you have to stress it at the right level, at the right part of the word. Otherwise, you come out completely different meaning, and sometimes it sounds a little bit funny, premature. Okay, so just like slowly. But they're good. I love to see everyone more interactive this time. I'm still not, we're up to the level of, you can't do presentation yet because it's still, a lot to learn. But that's, a bit of, starting point, and you learn from this one and get it on, and it's good. Ông Bụt Minh, you have anything to say?
Yeah, today seems like Anh Phú is less on cotton. Seems like Anh Vân is more. Yeah, but I think this setting is pretty good. The camera, the speakers make you much more interactive, and I'm very happy that you start giving feedback to your friends. That's a very good thing. Until you can see, until you can identify the problems, then you can learn. And in the future, you have to learn by yourself a lot. So only until you can identify where the errors are, then you can improve. You don't have Dr. Fu, Dr. Din here on the way to point out errors for you to correct. So try to have insights into what you are doing. That's the way you learn on the way in the future. I'm really happy that you start doing that. So keep up with that. But I hope that we should push for this speaker and camera this way from the very beginning, and save us a lot of time. This time it's just 2 hours and we finish almost everything. So that's great. Let's see. I think I have one more thing to say, but I forget already. I got sleepy.
Where are you sitting at the moment? I just wonder. I'm not sure. That sounds very strange structure there.
Yeah, it's a swing and roll. It's a swing.
Oh.
So it's kind of like floating,
The
right?
lock nets.
Bird nest. Yeah, and I guess some pronunciation. I think that that what I think we should improve. And on the light note about the last case, the patient is 19 years old, or not 19, 17 years old and pregnant almost term. So that means she's pregnant around 16 years old. So I'm not sure whether it depends where you work, but sometimes you need to report the case to the social worker to investigate whether it's just child abuse case or not.
Okay.
Like nothing serious. Oh yeah,
okay.
yeah. Actually, one more. No, I remember. So for this presentations, Dr. Fu mentioned a couple of times is that you present to him as present to a consultant. So the presentation must be more concise and to the point. Hopefully, we have time to show you several ways to present. Like if you present to your attendings after receiving the case, after after doing the H&P for the patients, then maybe the attending will ask you to report a very detailed to make sure you not miss anything. But when you present to consultants, they don't have a lot of time. Time is money, so they don't have a lot of time to listen to the whole case.
Yeah, we don't have money. Okay, we don't have money. We have time. We have time.
The longer you talk, the happier they're gonna be because they're gonna charge you more. So you have to be really concise and to the point on the negatives. You can say that on the negative is negative. Yeah, it's normal. And sometimes you present the case to the radiologist, for example. They just want like 1-2 lines about the case only to really do what you are looking for. And it's several versions of the presentations. Hopefully we have time to at least show you the difference so that you can help in communications in the future. I think that's all.
Okay, lastly, I'd like to remind class, some of you seem like, lack of preparation before, the class today. I know. I'd like you to know that you are busy, but we are busy. Everyone busy. So practice, and prepare. You can't go in the battle without preparing it. Preparation, and you're gonna get killed. That's why we try to criticize you all the time, because why? You haven't prepared well. So hopefully next session, please leave a lot of time. I know everyone busy. We are extremely busy, but we still got time for the class today. So I expect you to give a bit put more effort into it. And if you got many girlfriend, boyfriend, whatever, in the next few weeks, you don't see them, probably you won't kill them at all. Just put it aside, try to get most out of it by well prepared before you go in. And then we're happy, and you'll be happy, and then when no one can criticize you, and you learn more from this. Like Phú Trọng, whether he's busy, he good, he's very good. Even he busy drinking beer, but he probably all good. The way he prepare well, so that's good. So he saved money today, to buy the speaker. That's a great thing. You cut down smoke, drinking, very good. All right, class. Any other feedback? I'm going to play soccer. Okay. So anything else you want to add, Phú Trọng? You're probably the gang leader here. You can, on behalf of students, can say something.
First of all, I feel very glad because they have to be more active and we really saved a lot of time. I was thought that on my mind that because we can sit in the table and talk to each other, maybe we would have some new like debate. Like you can give us some issues, some cases, but not very clear details, so we can try to find others in order to have the final or the final treatment for some cases.
Yeah, I guess if the bandwidth is allowed, maybe we have 2 cameras so that you can see the whole class at the same time. Yeah, facing each other. Yeah, if the bandwidth allow, it is slow down the video and broken the voice, and it's gonna be difficult. Yeah.
Okay. But it's good.
Okay, class. Before we leave, I would like to tell you that we have 5 more sessions that you have.
Oh my God, that long.
Yeah. The next 3, we still have some topic to talk, and the last 2, that is like a final examination. You have to make assessment of your clinical communication. So now you already have to learn how to carry out the interview. You have to tell the patient that the patient education and now the presentation. So mostly that you go through almost the communication skill that you need in your career. So in next 3 sections, we let you give us the feedback that which field that you think that you need more practice. So instructors may concentrate more. Okay? Presentation, I think that the interview is you already mastered that. It's okay. But how about the presentation? And how about the communication? How about education? So those stuff that you need more, because everything you have a different skill. That's it. With the interview, you have to ask more questions. You have to templates to do. But how you educate it, how you educate the patient, maybe have different skills. Okay, and today you almost that you know how to do the presentation, even though that you not finish a good one, but it's a way that we do. Okay, that's it. I need you. Maybe you can give the feedback in our Facebook, and I tell you next week, Dr. Win. So I ask either Dr. Mindo or Dr. Brian do the sessions. So far, I'm not sure about the confirmation of Dr. Brian yet. How about Min?
Yeah, I got to look at the schedule, and then it's a Memorial Day weekend next week. So yeah, we need to check.
Okay, thank you.
Yeah, I'll let you know.
Okay. Anything else before we leave? 1:30 in my time now. It's 1:30 in the morning now. Okay. We can leave now, huh?
All right. Good night.
All right.
Good morning. Good afternoon. Bye. Bye. Bye.